Welcome, everybody, and we are very, very happy to have you with us today. We are going to be discussing an important topic to all of us, which is the lingering COVID-19 vaccine hesitancy in 2023 impacts on the ongoing pandemic responses and effects on other routine immunizations. My co-host and co-moderator and friend, Jeff Lazarus, will give a general introduction about the study, which is actually the most recent in a series of multiple studies that we have conducted as a research group on a global basis. And the results that we will share with you today is based not only on the most recent results, but those of the preceding comparisons from 2020 up till the present. Jeff?
Thank you very much, Dr. Mohandes, and welcome everyone. And in a moment, I'll introduce the panelists. So, as was mentioned, we're holding this meeting, as you know, on the occasion of the 1 year since the publication of the Nature COVID consensus, which really set out a series of recommendations about how we can end COVID-19 as a public health threat. And I'll come back to that, but that started with the expectation back in 2020 that if we had an effective, safe vaccine, people would take it. It would work, and we would be able to mitigate and ultimately eliminate the pandemic. So we'll be looking at some of that data. The first was published in October 2020 here in Nature Medicine. The second was published a year later. At that point in my career, I was thinking, surely we won't be doing a third. Surely people now know that the COVID-19 vaccine works. We've seen the incredible effects. We're still struggling with inequities around the world, but everybody knows what happened. New waves, new variants. We did this again. We have the third study that came out earlier this year with 2022 data. And then, as Dr. Mohandes just mentioned, we've just done the fourth study, and that's the data we're going to share and discuss with our panelists, all within the context next of how do we end COVID-19 as a public health threat. We know we need a vaccines plus approach. We need to go beyond just vaccination, but if we can't even get enough people to vaccinate, then we will continue to have what we've called a lingering issue, but really it's a rather serious issue because we will culminate by discussing issues around pandemic preparedness and what does this really mean for the future, thinking beyond COVID-19 if we have challenges in acceptance of a vaccine that has been proven to be shown safe and effective. Next. Let me introduce our panelists you've already met. Professor Mohandes, the Dean of the City University of New York Graduate School of Public Health and Health Policy, where I'm a professor of global health as well as a research professor at the Barcelona Institute for Global Health part-time. We're joined by Dr. Rocío Sáenz Madrigal, who's the former Minister of Health from Costa Rica, was part of the Lancet Commission, was a key part of the Nature COVID consensus, and will be speaking to us from her unique perspective in Latin America. She will not stay for the whole meeting, but she will present the perspective from Latin America. Dr. Nina Schwabe, the principal at Spark Street Advisors and well known for her sharp analysis of how we're responding to the pandemic, issues around governance, and particularly the treaty and preparedness issues. Dr. Scott Ratson, a distinguished lecturer at the CUNY Graduate School of Public Health and Health Policy. I met Scott already in 1998 at the World Health Organization, and he's one of the strongest voices globally on vaccine hesitancy. Dr. Kenneth Rabin, a special advisor at the Journal of Health Communications and a senior scholar at CUNY SPH, and almost Dr. Trent White, finishing up his PhD, a health systems expert with a background in the World Bank and who's a PhD student at the Barcelona Institute for Global Health and also a researcher at CUNY SPH. Next. So let me pass over to you, Dr. Sáenz, to talk to us about the situation in Latin America. Often we've been, very Euro and US centric in addressing this pandemic, but you've been on top of organizing stakeholders across Central America, South America, and the Caribbean. So over to you to share your insights. Thank you for joining us.
Thank you. Thank you, Dr. Lazarus and all the organizers to bring me the opportunity to have with you this reflection and perspective around the Latin American region, especially in this moment of the world that all the people needs to be safe, all the people has to be secure and without any crisis all over the world. The next slide, please. I would like to start my presentation to talking about a little bit about our context. As most of the people here with the attendance know, we are a region with a multi-ethnic and multilingual region with the deepest inequalities, social inequalities in the region. With our systems are very fragmented and segmented and underfunded. But the good news is that we have a long history to national program for vaccines. Since the 70s, 80s, with the support with the Dr. Ciro de Quadros in the Pan American Health Organization, for the support from the governments, the countries in the region has a long history for the national programs in vaccination. And in the past, we were really proud to avoid the cases of measles and polio and so on. And for that, when the COVID-19 arrived in the region in the March 2020, we were very exciting and expecting how will be our response, integrate response, include the global public health professional. But in the first days, it was clear for us that the limitation that we have in the human resources in intensive unit care, but also in the primary healthcare and the community programs. Also, we documented several projects, several data about how the indigenous communities established their own measure because the time of the no-get guidelines from the different parts of the world, especially in the Amazonia, but also in other indigenous population. And also it's important that at this moment, our region had the highest number of cases and highest lethality. And unfortunately, this situation involved also our health professionals, our providers. And this is really very sad for us. And this situation put all the public health arena looking how we can, really be prepared better for the next crisis, global crisis, or the next pandemic. Also, was clear for the Latin America the dependence of the medical supplies and the vaccine on the global production. And this is one of the reality that we have still yet today. And I expect to really this can change in a couple of years. The next slide, please. It's important to bring to the table that the report from the UN Agency for the Children and the Pan American Health Organization bring the report in this year, and they highlight the topic with the 1 in 4 boys and girls lack vital vaccines. this is putting our coverage behind 30 years ago. This is a very bad situation for our region, and with this big experience that we have in the past. And this is one of the lessons learned that we have to really highlight regionally and globally. It is not possible in the next crisis like the COVID-19 that the successful to attend the crisis, we have to leave the successful in the programs to save life, especially for children and for the most vulnerable people. And as a global professional, we know and recognize that the vaccine and the vaccination and the immunization is one of the simplest and most cost-effective public health intervention. And for that, we and I assume this to us, to the government and the partners, must invest in vaccination and in primary health care. Why primary health care? Because the vaccination has to be close to the people, close to the communication, close to the professional, in the communities, really to bring these national programs very strongest has to be with the primary healthcare very strongest and strengthening the different people that they are working in the communities, especially rural areas, but also in the urban areas that they are not have normally access for healthcare. The next, please. I was part, as Dr. Lazarus mentioned, about the consensus 2-3 years ago. And when I was preparing this presentation, came my mind, do we have really a consensus? Do we have really a consensus that the national vaccines programs must be included in the preparedness for the next crisis or next pandemic? Do we have a consensus to the access of the vaccine is needed for the most vulnerable people? Do we have a consensus to really increasing the production on the region of the vaccine and the different supply that we need for the next crisis of pandemic? Do we have a consensus really to how to approach the doubts, the myths, and the social concerns about the new vaccine? Or do we have a consensus to establish the platform to address and to fix the communication, fake news, and the misinformation? Do we have a consensus in how to bring equitable vaccination programs that demand that they really for the people that they needed this kind of program? If though we have a consensus, is not a time to really go forward and put the platforms to build the better response and better preparedness? If this is the way, we, the people who are today here attending, and all the people all over the world, we are expecting, if they really do we have a consensus, please, we will have a better future for the next generation. Thank you very much.
Very much, Dr. Sands. It's great to hear your perspective. One thing that struck me was what you said about indigenous communities, or indeed indigenous nations, starting to organize themselves, in the absence of any guidance. I was just wondering if you could elaborate on that. I mean, was there coordination between indigenous groups within countries, in different countries? I mean, how did that really work?
I think it's of course you can be prepared for really take this situation that there was worse in Latin America, and I am sure we can support and strengthen the response and learn some on other countries that like New Zealand and Australia, that they bring different kind of response inclusiveness. And I think as we are in the global arena, we have to learn, we have to put and has the open the minds and the mind to really try to do a better job in the next times. This is a ethical issue.
We do have, I know you have to leave in about 5 minutes, but we do have time. If anyone wants to make a comment or question, I know there's people on the call from also from Latin America, but really from anywhere in the world. If you want to make a comment on, you know, the situation in Latin America, the situation now, or anything that was unique in the response, like what was mentioned about indigenous groups organizing their own response. Dr. Hernandez?
Thank you. Professor Sanz, a very, very important presentation. Thank you so much. The question I had for you was the availability of materials used to communicate regarding the COVID-19 vaccine, and whether there was collaboration among Spanish-speaking countries to share materials that were linguistically and culturally sensitive and informed. Did you find that to be useful, or did each of these countries find themselves in a situation where they had to develop their own materials? What collaboration amongst the Spanish-speaking world occurred in that realm of communication?
Yes, at the beginning of the response of the COVID-19, each country tried to build their own response, and this was take time to really elaborate all the communication and try to put all the knowledge was flowing all over the world to put in a best way. I think at 6 months and a year, the countries start to share through different experts how to build, how to do it better, and not pass for the same steps, you know, but because they delay the response, especially to build a very good and clear message and how to respond not only in the health system, but also how to bring this information for the public, and how we can, you know, really establish the collaboration with all the social networks and social different groups and the media, the professionals, the doctors, the governments. And I think this was one of the lessons learned, that we need a platform to really look for this misinformation and the fake news, because was repeated in each country the same history and the same problem. And you know, the access is very nice in Latin America, the access for internet, but sometimes this misinformation bring very strength and stressful for the ministers, for the professionals, for the doctor, and they don't know how to approach. And I think this is a very, very good lesson learning, how to have this kind of platform in Spanish or in Portuguese, because we have a huge country here in Latin America that they speak Portuguese, and also how to learn how to bring this information useful and opportunity. And for the next time, I think we need more clear participation for the different groups and the media and the social networks to be part of the response, not to be part in front of, the people who were trying to do the best for the population.
Thank you very much.
Yes, thank you, Theo. I mean, there's so many different languages and cultures across Latin America. I think it's a particularly challenging region, and I know the indigenous groups have their own forms of networking and governance, even with each others, as well as with the governments of the countries that they're in. So hopefully this kind of collaboration will continue and will be and need to be considered in national responses moving forward. I see a comment just also just saying sort of the same thing that thank you for highlighting that response. I mean, what you pointed out was really the failure of governments to both do what they agreed to do in the international health regulations, the failure of the IHR really, but also to listen to their citizens, to listen to the people in their country and make an adequate response. So I'd like to thank you for joining us. Wish you the best for the rest of the day, and thank you for the collaboration really over the last couple of years. It's been incredible to have your insights as a former Minister of Health, and with the large network you're coordinating across Latin America. I'd like to say I look forward to future collaboration, but if it is future collaboration, it's probably because we continue to fail in our response, including in increasing vaccination. But I will look forward to our future contact. I'll pass back to you, Dr. Almohandes. I also see your hand.
No, I was just saying thank you and applauding.
Okay.
My
So
pleasure.
I will pass back to you, Dr. Almohandes, to take us through some of the findings that will inform the next part of our meeting, where we're going to discuss with the panelists, but really all of you are welcome to engage. These are unpublished findings from the 4th global survey looking at vaccine acceptance in 23 countries. And it was a lot more than just the earlier survey of 2 questions. Now we're really understanding what else we need to understand a whole range of issues around trust in science, trust in authorities, and so on. Over to you, Dr. Almohandes.
Thank you, Jeff, very much. My name is Ayman Almohandes, and I am the Dean of the CUNY Graduate School of Public Health and Health Policy, the Public School of Public Health for New York City. It gives me tremendous pleasure to participate with you today. I will present some of the data that we have assembled over the years, starting in 2020, a collaborative effort between the CUNY Graduate School of Public Health and Barcelona Institute of Global Health. We thought it would be valuable to start a survey looking at the potential acceptance of a COVID-19 vaccine at a time when the vaccine was still in development. Once the vaccine was produced, we repeated that survey, expanding the number of countries. We started with 19 countries and 19,000 respondents. In 2021, we expanded the number of countries to 23, representing more than 2/3 or almost 2/3 of the global population. And as you can see, when the vaccine was an idea, the willingness to take the vaccine when and if available in 2020 was about 71.3%. And the following year, after the vaccine was actually produced, the question became, have you received at least 1 dose, or are you willing to take the vaccine when made available to you? And the percentage increased to about 75%. And the following year, we asked the same question. As you can see, it's almost predictable of about a 4% increase between these 3 years, 2020 as a concept, 25 actually vaccine available, 22, 21, and 79 in 22. And then this year, when we did the most recent survey on the 23 countries, we felt it would be probably more appropriate to simply ask whether people had received 1 dose of the vaccine. And as you see, 87.8% of the respondents said that they had received at least one dose. You know, in the global health arena, during the global response, we can either look at this as a glass half full or a glass half empty. And as an optimist, I prefer to think of it as more than a glass half full. Having said that, you can see that this is not a small percentage. As I said, about 65% of the global population represented by this survey. So in a way, it is somewhat representative of a global trend. The next slide, as you see, looks at something that is perhaps more pertinent and more timely. And we asked that question in 2022 amongst everyone and amongst those that had received at least one dose of the vaccine. And at that time, we were beginning to address the issue of the booster. And as you see in 2022, about 71% of the respondents said that they would take the booster. And amongst those that had received the vaccine, the percentage was higher, at about 88%. Now there, you know, whether it be booster fatigue or a general perception of the virus being less virulent, but unfortunately, in our most recent survey in 2023, you can see that the response is down. Amongst everyone asked, from 71% in 22 willingness to take the booster, only 63% this year. And amongst those that had been vaccinated, down again from 88% to 71.6 or 72%. We asked a series of questions related to trust in a variety of dimensions. The first being, I trust the science behind the COVID vaccine. And in all of these histograms, the top line is the first year, 2021, when we asked the question, 22 and 23. And we were interested in that question because of the prevalence of misinformation increasing over time, and we were wondering if the level of trust was dropping or increasing. And as you see, between 69.8% to 70.2% to 71.6%. I'm not sure that the differences here are dramatic, but you can see that there is a trend where the trust in the science behind the vaccine at least is not decreasing over time. The question of safety of the vaccine, initially the level of trust and safety was lower at 65%, and over the past 2 years, the trust in the safety of the vaccine increased to 67 and 69, and now about 70%. And then when we asked that question, which is an important one, which is that the risks of the disease are greater than the risks of the vaccine. Now that was an interesting trend. And as you see in the very early stages of the pandemic, people experienced a very severe expression of risk during COVID-19 early stages. No treatment at that time, and the vaccine available, but still a lot of populations seeing a high level of morbidity and still mortality. And so in that question, the disease is more, the risk from the disease is greater than the risk from the vaccine. You see that 75% in 2021 said that was their perception. It decreased to 71.6% in 22, and in 23, it is again lower at 70%. It will be interesting to see if that trend continues and to what degree over time, which of course will influence people's interest in continuing to take the booster and using other forms of protection during surges of the viral infection. The next question we asked, which COVID-19 can be prevented by vaccination, and as you see, there is little fluctuation over 3 years, hovering around 73% of the population believing that COVID-19 can be prevented by vaccination. The next question was, COVID-19 is a dangerous health threat. And again, as we saw from the previous question, comparing the risk from the vaccine and the risk from the disease, in 2021, 91% of people thought that COVID-19 was a dangerous health threat, and only about 76%, a very significant drop in that perception over time. The next slide is an important one, where we are looking at the impacts of the trust in the COVID-19 vaccine and the experience with the COVID-19 vaccine on the trust in other vaccines generally. And the question we asked was, the COVID-19 pandemic has made me more willing to get vaccinated against other diseases. So we asked the question in the positive with the flu, measles, hepatitis B. And as you see, 61% said that they feel that their experience with the COVID pandemic increased their likelihood to get vaccinations against other infections. But it is also still notable that more than 20% of respondents strongly or somewhat disagreed with that statement, meaning that the information they received or their experience with the vaccine or whatever has decreased their enthusiasm about vaccinations to other infectious diseases. That is a population that we need to focus on and perhaps better understand what aspects of their experience during COVID has led them to that response, which is a fairly serious one. Finally, the next slide, impacts on trust in other vaccines. We asked with their experience with the COVID-19 vaccine, my experience with COVID-19 vaccine has affected my trust in other vaccines. As you can see, 31% said that it had increased their trust with the vaccine, which is much higher than the population that said that it had decreased their trust in the vaccine, and the majority, half of the respondents, said that it had neither increased nor decreased their trust in vaccines. The next question, we asked about the broadcast media coverage on COVID-19 and how it has affected my trust in other vaccines. And again, I would say I would reflect on that response positively when 28% said that the broadcast media coverage on COVID-19 vaccine had increased their trust in other vaccines. While again, about half people said it had no effect. And despite everything that we have seen in the media, only about 15% of the respondents said that their exposure to broadcast media had decreased their trust in other vaccines. And then finally, the same question, more or less, on social media coverage on COVID-19 vaccines has affected my trust in other vaccines. And we see that the response to these two questions is not dramatically different. Broadcast media, 28%, social media, 26% said that they had increased trust in other vaccines based on their exposure to the internet. Again, more than 50% said it had no effect, and somewhere, close to 15% said that it had decreased their trust in vaccines in general. Again, I will stand by my general impression based on the results so far, that the glass is half full rather than half empty. I hope that this will stimulate a conversation amongst the audience and the presenters today. And I would like to invite the panelists to participate, if we don't mind removing the slide from the screen at this point and opening the floor for discussion. I wonder, Trent, are we able to do that? Revert to there you are. Thank you so much. So again, I invite my colleagues. I see we have Scott on the screen. Ken, are you there? Yes, he's on the screen. He'll put himself back on video. I see Nina, hi, how are you? And Jeff, we're all ready to launch into that discussion. And, we will focus the first part of our discussion on the materials that I've shared with you so far related to the impact of COVID-19 on routine immunizations and the trust in the vaccine. And the first question I'd like to open for a response from you all is, what shifts have we seen in public demand for COVID-19 vaccine and for routine immunizations? I touched upon the results that we have assembled from our most recent poll that we've just completed. As I said, the first 3 years were published in Nature and Nature Medicine and Nature Communications. The most recent poll, we are still have not finalized our publication, but we hope that it will be available in the scientific literature soon. And how have concerns about COVID-19 influenced? I'm sorry.
Yep.
And how have concerns about COVID-19 influenced perceptions and attitudes about other vaccines? Scott, would you like to answer that?
Well, thank you, Dina Mohandes, and thank you, Jeff, also for the great intro and setting this all up and putting these into motion, not only the number of surveys, but also, of course, consensus and other pieces that you've mentioned. I think there were a couple things that stood out from the first couple presentations. The former Health Minister Sayan's on the slide that had 1 in 4 boys and girls lack vaccine coverage, and put us back where we were 30 years ago. We've seen that throughout the world, and it's slipping for a whole number of reasons. And we can continue to come back to that, notwithstanding, of course, the trust and the challenges that we had during COVID. But I think, Dean, if I can say, one of the things that you said when you showed the slide up, impact on trust in other vaccines, where you positively said that 61% are more willing to get vaccinated against other diseases because of the COVID pandemic. That's sort of how we worded it. But you said something that you said it's fairly serious finding when you think about that 39% of people are less willing to get other vaccines. And I think that is one of the most important findings that we're seeing, is that the negatives are getting stronger. And of course, this is preliminary data that's aggregated and so forth. The negatives are getting stronger, and shall we say, the positives and the reinforcement to get vaccinated, not only whether it be with COVID, with others, are whether static or only going up slightly. And I think we really need to unpack that. And I've been looking at other surveys, of course. I mean, this is our survey of 23 countries. There was a recent one just reported actually yesterday on CNN by the Annenberg Center on health knowledge, and they've been tracking people as well. And they're finding similar pieces on the negative nature of people believing that vaccines are full of toxins and harmful ingredients. And that number is going up significantly. People are thinking that mRNA vaccines against COVID also cause cancer. That's going up. And you see that amongst, as we unpack our data, other parts that are not just US, but other parts of the world that I know we might talk about later. But I think that's one of the newest findings. I know I like to say it's half full, and it is full, that we are getting to a number that we used to say, you know, whether we didn't like calling it herd immunity, community protection, whatever it might be. But the negative part, and I think also which was highlighted not only by, again, a former health minister, but also now was highlighted by the Global Preparedness Monitoring Board, another WHO and World Bank piece that came out earlier this week, that we don't have an effective way to address the misinformation and the disinformation that's contributed to the global trust deficit. So I know these are things we'll come back to, but clearly the data that you presented begs the question of why people are disagreeing with their willingness to get vaccinated, when frankly the vaccine for COVID clearly has ended the pandemic in many people's minds, and there's a lot that we still need to do. So those are my initial comments at this juncture.
Jeff, would you like to add anything?
So, no, thank you, Scott. I mean, I guess, you know, one of the biggest challenges we've seen is, has been, you know, how the disinformation linked to COVID-19 has spilled over to the other vaccines, as you mentioned. And there's lots of surveys, and we're seeing lots of differences. 1 in 4, you know, is a big number that Dr. Saenz presented, but it's much higher in certain populations and it's much higher in certain countries. So we're seeing, you know, this can be over 50, 60% not getting vaccinated in some settings. So, so I guess it's just to remember the equity issue, to remember what's impacting, you know, things we know, but I mean, what's impacting in each setting and how we overcome it. Because, you know, we have big picture issues that are concerning, and some people might say, well, it's only 1 in 4. But, you know, when we have a disease like, you know, COVID and spread of SARS-CoV-2, we know that the mutations pick up when you start to have concentrations of well, people who aren't vaccinated, and where there's spread and susceptibility. So I think that's really just my main takeaway from that finding, that, you know, we, you know, as Dr. Omohande showed, you know, some of the numbers go up and some of them are promising, you know, when you start to hit numbers of, you know, over 85% have been vaccinated. But again, it's like work we've done in HIV and other fields. When we look for the 390s and the 395s to have success, that's 5 to 10% that aren't. That's 1 in 10 people. And so in this case, and again, that's also concentrated. So I think it's still very concerning. And I think we need to both look at why those numbers are going up and applaud it, but also look again, you know, it's the classic sort of last mile situation. How do we don't reach all 14% who aren't vaccinated, you know, how do we cut that in half? And what does it mean, as we'll talk about, you know, for the other vaccines, but also for vaccine development in general and possible new pandemics?
Thank you. I'd like to move to challenges, and what challenges do vaccine distribution systems face? It's an important element here, and I know we have an expert sitting amongst us here on issues of vaccine distribution. And what role can global health organizations like Gavi and CEPI play in strengthening immunization systems around the world? Nina, could you tell us more about your experiences with that and your thoughts on that?
Sure. Thanks so much. And thanks for including me on this panel. I'm learning a lot, and it's taking a lot of notes about things we need to think about moving forward. So there's a couple of things about vaccine distribution. There is the macro. So does it get to the country? Then does it get to the state? Then does it get to the city? Then does it get to the individuals within the city that need it? And I think as we think about vaccine distribution, that's a pretty complex chain that needs to be unpacked and fixed at pretty much every stage. I'd like to start with the micro and then go back to the macro. So on the micro level, and as we heard, I think both from the results of your survey as well as from the former Minister of Health, we really need to think a lot about that last mile distribution part, and are we getting it to the people we need, which is very different from, and not necessarily related to, do we have enough vaccines in the storeroom? And again, maybe we can come back as we go through the next couple of hours to come back to that specific question. In terms of the big picture organizations, there are organizations trying to work on vaccine equity and trying to ensure that there is equitable distribution. And one of those is Gavi, the Vaccine Alliance, which is a private foundation based in Switzerland, which focuses on mass procurement of vaccines for low-income countries. And in the case of COVID-19, they also worked on middle-income countries. They're sort of like a buying club for vaccines. So the idea is if you can buy in large bulk, you can drive down price, and then they work with countries to enable distribution. They work primarily at the central level, so they work with governments, but they also provide systems to those governments to help them strengthen their system. So that's one, and we can talk more about Gavi and their role on the COVID-19 vaccine specific if we want to get into more depth. And then there are organizations, CEPI. They're not really organizations like CEPI or Gavi because they're pretty unique in the global health ecosystem and ecostructure. CEPI is a product development partnership which focuses on developing drugs for diseases of epidemic potential. And they have a series of vaccines that they focus on. I like to tell my family, diseases you've never heard of, but which will certainly kill you. That's the way I describe the work that I do with CEPI. But MERS, Lassa fever. And luckily, they were working on mRNA vaccine technologies prior to the COVID-19 outbreak. They also they have within their portfolio something called Disease X. And Disease X is the thing you've really never heard of because we don't even know what it is that will certainly kill us all. So they're, again, a publicly funded organization, which also gets money from private foundations like the Wellcome Trust and like the Bill and Melinda Gates Foundation, specifically designed to be ahead of the curve on designing vaccines and thinking about production and manufacturing at scale so that when and if the next pandemic hits, the world will be ready with vaccines. I'll just sort of close on, clearly SARS-CoV-2 was something that nobody had ever seen before, and the scale and breadth. If we look at other epidemics and pandemics that we've seen more recently, if we look at the ones that are public health emergencies declared by WHO, Ebola was pretty localized. Polio is now, it was completely widespread, but now polio hotspots are limited to about 3 countries. So I hope, and I think we're all hopeful, that a pandemic that hit us all at once, all over the world, was kind of a new thing. And speed of travel, openness of borders, that's never been seen before. So my hope is that now, in terms of thinking about that global distribution, we'll be more prepared. And there are lots of efforts underway to do that. There's a treaty, which I'll talk about later today, under negotiation at the WHO, which is saying, look, people, we need to set aside 20% of all products produced so that they go to low-income countries. Gavi is working on how can it incentivize regional manufacturing so that we don't have just production mostly in India and in high-income countries, but there's also production in Latin America. There's also production capacity in Africa. There's also production capacity in Southeast Asia. So a more distributed production capacity. So lots of things we can do at the top end. And then again, we'll come back, I think, later in this discussion to the last mile, which is a completely different kettle of fish. Thanks.
Thank you, Nina. A lot of very important information. A sobering comment from Carlos Gershenson from Mexico. He says, in Mexico, more than half of 1-year-olds lack their recommended vaccine. This was already problematic before the pandemic, but things got much worse, and they don't seem to be improving soon, which leads to the last question I have for the panel on mitigation measures. What measures have been taken to mitigate disruptions in routine immunizations? Nina, you touched on that already in your response. And what innovative strategies have been deployed to ensure continuity of routine immunization services? And is that going to be country specific? I believe probably needs to be, right? There are different kinds of obstacles in different countries. And thanks to organizations, as you described, Nina, you have a professional expertise that can come in perhaps and assist. But who would like to tackle these questions specifically?
Maybe I can start a little bit on the global side. I think there's a lot of effort in terms of the global public health effort on catch up. I think one of the big errors that I hope we don't see again, the next pandemic or disaster or whatever it is that when we think about closing health systems or we think about lockdowns, that we really consider immunization and childhood immunization as an essential service that stays open at all costs. So education, immunization, because it is sort of hard to catch up. There are, especially in low-income countries, where there are limited opportunities for interactions with the health system. And as kids get older, it's harder to get to them. It's pretty hard to catch up. So I think I'd love to say we had the answer and everybody's catching up, but I think the real answer is everybody's still struggling to do the catch up.
Thank you, Nina. Very appropriate. I will hand the microphone virtually to my dear colleague, Scott Ratson, and he will be presenting briefly on the preliminary results on trusted sources from our fourth global survey. Scott is a very dear colleague who has contributed so much in the area of health communications during his career, and we're very, very happy to have him on this panel and as a member of this research group. Scott, the microphone is yours.
Thank you very much, Ayman, and I really appreciate the opportunity to have been engaged with these studies from the beginning. And as mentioned earlier, we've had not only these 4 surveys, but I've been engaged as editor of the Journal of Health Communication in this field for quite some time. And we have a number of other articles that come our way, but there's no survey that has been looking at this in the same way amongst our research team, both with CUNY School of Public Health and ISGlobal and others in our network. And these are just 2 pieces that I think are very, very important. And it's not insignificant, to use my double negative, of putting together the way to ask the question to try to ascertain what people trust and who they trust. And we thought this was the best way to ask, or how people were satisfied with the communication efforts on COVID-19 vaccines made by my health authorities in my country. So this could mean very different things, all the way, of course, for local, county, state, province, what may be. But for the most part, people, 72%, you might say that's good. 2/3 are okay. Over 2/3 are happy with communication efforts. But again, I think we need to continue to unpack what these are in terms of the 10% that are unsure, which is you're not really satisfied either way, but almost 15% there. So a good percentage are not, and we think we can do better. So we thought the way to look at this was, who is the most trustworthy source? And it's still a difficult question. It was the source and the information where in people's minds, when we've done some pre-testing, that they trusted the source and the information from that source. So it was, I trust the authorities, and we continue to find that the organizations, the national and other health authorities that have legitimate support, whether it's as a member state organization or a funded organization, so it would be a member state with WHO, a funded organization, the ECDC by the European Union, the CDC is an agency in the United States. Those still have amongst the top, as you see, trustworthy source of information. Now, I would like to preface all of this by, this is on a 10 scale. And it would be nice if we were able to move all of those numbers up. We haven't, done the comparison yet to see why are all of them so low. But if we also mirror this and look at other surveys that have been done for quite some time on trusted information, such as the Edelman Trust Barometer for years, this is similar that people, are never at the top. And it is similar that national health authorities are trusted. But then we go to the other sources that are here. And the doctor or nurse, if you look, is the highest one, the health professional. But it's not a doctor or nurse, it's my doctor or nurse. So there's also that actual connection with that individual that is really key. And I think if you ask the same thing, if you trust politicians, well, if you do, they are less apt to do it, but oftentimes they'll be more trusty of their politician. So there's those pieces are something also that we always try to unpack and trust, because there is a different kind of relationship. And there are many people in the field who study trust, that trust are about relationships. And the relationships with these organizations are also established with a public face of somebody, as well as continuing for transparency on the source. So top piece here from the finding on the right is doctor or nurse is number one. Number two are the health authorities that have the legitimate authority, all in the 6.4 range. And then surprisingly, or maybe not surprisingly to many of you, family and friends and other people they have a connection with, people they work with, their employer, the government that could be in their area. So it could be their local government. It could even be down to the school board making a decision if the school should have masking or other pieces that are there, even though this question was all about vaccines. And then, finally, while many of us often think that, social media is the most ubiquitous, it is the lowest on this list, and it continues to be. And while we think it is the major way that people get information, it frankly is not the way most people get information, but many people do. And not to forget those intermediaries that are still there with the news media. And let me just finally say, not to discount religious leaders that are lowest on this among social media. I think it's very different both by country and both by individuals as we unpack it. So I guess the big answer is not that we were putting what would happen from the Vatican versus others, where have both global reach. We need to unpack that, and religious leaders can be very, very important in terms of the trustworthy information, particularly on both sides. It's two-tailed about telling people to get vaccinated, and similarly there are unfortunately those that tell them not to get vaccinated for religious reasons. So we need to continue to focus and help understand that. So with that, I think the trust issue is the biggest issue that we want to continue to build. Heidi Larson has done listening on this. We've continued to explore ways that we can build trust and unpack it more. And I think that's something we hope to get it back in the discussion. So Dino Mohandes, Professor Lazarus, over to you on how we address this.
Great, thank you. Thank you, Scott, and thanks for walking us through those results. I mean, the issue of trust has just been fundamental, as you mentioned, in the pandemic and in healthcare in general. And you rightly pointed out that, one issue is around authorities in general, whether it's the CDC or WHO, and another is around, it's my doctor. I trust my doctor. That's both good and bad, depending on the doctor's position on some of these issues. And this is what's made this whole situation so incredibly complicated. So I think it's clear that trust is diminished during the pandemic. There's been concerted disinformation efforts, but I mean, what are some of the ways that we can be mitigating this? And I wonder also, Ken, I know you're working in this field. You're both at the Journal of Health Communications, where you're chief editor, Scott. I mean, from the journal and from the other evidence you're seeing, I mean, you mentioned the listening study that Professor Larson and others are carrying out. So we're hearing things on social media, but how are we able to respond? How are we able to build back trust?
One question. Sorry.
It's not going to
Ken?
be easy.
Yes.
I think that's the first thing to get out on the table. Scott and I have been working recently with a very bright pediatrician named Rebecca Soskin Evans, and she shows a curve that says once the damage has been done and trust has been lost, the process of restoring the kind of trust we need to get buy-in to vaccination programs, to get acceptance of good, sound advice, whether it comes from your healthcare provider or whether it comes from the Centers for Disease Control, to get back to the state where perhaps we once were, although, you know, in hindsight, everything was better 20 years ago. In fact, there has been a serious erosion of trust. And one way we can see it is that finally, our colleagues and our, you know, people like us are actually taking on the issue of communication, of trust, of combating misinformation on a fairly serious level. Scott and I are putting together a council on quality health communication, but we're also collaborating with a coalition on trust in science that just in the US alone features the collaboration of more than 80 medical and health societies that are concerned about addressing this problem in a systematic way. And the problem that we face is that the sources of misinformation are much better organized. We really have a battle on our hands. And we're not the kind of people, as scientists, as public health practitioners, who are used to fighting battles like this. But fight we must. At least that's what I think.
Yeah, thank you, Ken. I wanted to bring to your attention a question from the floor. Joseph Adoyo was asking, I would wish my curiosity to understand how vaccine acceptance hesitancy has shifted amongst healthcare workers post-COVID-19 vaccine. I think it's a good question, simply because of what Scott said and what you reiterated, Ken, about the role that healthcare workers can play, so that their own trust in vaccine. And I did ask Trent, a member of our research group, to perhaps put on the chat the link to the work we published, that was published with our Canadian colleagues, on the issue of healthcare workers globally and their trust on the vaccine. But Adoy, Joseph, forgive me for addressing you by your first name, but it would be interesting perhaps over time to see what the trust looks like. And he lists, and perhaps Jeff has some experience with that, the leads. Did you categorize the respondents in work they do? He's asking about the hesitancy or the compliance to hepatitis V vaccination amongst healthcare workers. Does anybody have information about that, or we can certainly research it?
I mean, so we and thank you, Mr. Doyo. You know, we do obviously, you know, capture source of employment. The numbers of healthcare workers per country would provide too low a sample, and it's a bit random in the not way we want, because you know, we didn't wait and look for particular work categories. But when you bring it all together, yeah, there's hundreds of participants in the survey who were healthcare providers. And I think, Trent, you can share the earlier study we did with our Canadian colleagues. There it is, on vaccine hesitancy among healthcare providers in 23 countries, because this is the crux of the issue. If you know, on the one hand, it's great, you know, as Professor Watson mentioned, you know, share that there's great trust in your own doctor. But as I mentioned, if your own doctor is opposed to the vaccine, we have a problem there. And this is really, I think, one of the key issues. we need to be addressing. We need to really drill down and say, who after the doctors, and what's the role of the pharmacists, family members, religious leaders, and how do we handle that tension there? Now, regarding hepatitis B vaccine, I mean, there are huge ongoing efforts. Nina might be more familiar with some of them, at least from the time you were at Gavi, but we'll be scaling up hepatitis B vaccine now with Gavi support for the birth dose. Some of the countries that didn't have hepatitis B as a part of their routine childhood vaccinations, like Denmark in the EU until recently, have added it on. And there's sort of indisputable data, going back decades about the amazing impact this vaccine has on not just hepatitis B, but liver cancer that would have been caused by hepatitis B. So we often call it a vaccine that prevents cancer as well, since it's so closely linked as a causal pathway. So we didn't, in this case, specifically look at hepatitis B, but we know where there's vaccine hesitancy, it creeps over to childhood vaccination programs, and I would expect hepatitis B to have suffered to some extent from the general challenges to the COVID-19 vaccine.
Thank you, Jeff. I think also we're talking about the building trust, and there's no question that involving communities themselves in the process of messaging and partnerships is really a very important aspect of building trust. And your very important seminal paper and the consensus paper, you did point to a whole society approach towards the pandemic response. And this can be translated into a whole society approach towards building trust as well. If it's coming only from one direction, and if it is not sensitive to priorities within the community and an understanding of a whole society approach towards combating a pandemic, then that in itself may perhaps impact on trust.
That's right. And I mean, regarding, community engagement, I don't know if any of the panelists or really anyone, on the call would like to talk about some of the examples, positive and negative, but I mean, how we've been able to engage communities in the response. I thought Dr. Sands gave a very nice example of Indigenous communities organizing themselves, but in other settings, if anyone has any examples to share.
Yeah, well, that's a good call out, and I think some of the Canadian colleagues from 19 to 0 may be on this, and they might want to speak about it because they've had a lot of good success in Canada. But in the meantime, we also have a community that is very trusted, business and employers, and through Business Partners to Convince, we've had these business partner roundtables, and thank you for presenting the consensus work in the past. Professor Lazarus and others have also brought information there that includes WHO, CDC, a lot of the other multilateral organizations. And to answer the question of how we bring the community, and I think the multi-sector engagement that you're suggesting, Jeff, is still important. And there's just 3 other pieces that came out on also beyond your consensus, but with these roundtables that are continuing to probe, which both you and Heidi will be presenting, Professor Larson, in a couple of weeks, that we know that, one, facts don't change minds alone. So how do we build trust? By using emotions, narratives, stories, communication, building a network of spokespeople, creating credible sources that are trustworthy, and use the appropriate technologies. And if we don't do it, unfortunately, the flip side is the AI will do it, and other people using it on the negative side will be smarter than all of us. 2, I still think, as we brought up by their data earlier, we cannot let the hesitant or skeptical aside, because they continue to strengthen and the mainstream continue to be the same, and that will erode, as we're seeing, just chipping away both at our surveys and in other surveys. And then 3, I think we have to acknowledge that we are not as organized, and disinformation is a business. and eroding trust in institutions that are being done. And I use the word disinformation, which is usually the intent. Sometimes they're from other states, states as in countries, they're state driven. But other places they're driven by people with motives that are either financial or just politically, ideologically against science and frankly a functioning society. So we need to help identify those and try to overcome the trust issues by one, calling them out, and then building those pieces together with the multi-sectoral pieces. Much of, like I think Ken just mentioned, that's why we have coalitions of trust in science. That's why we have, Professor Peter Hotez writing a book, The Deadly Rise of Anti-Science, and reminding of the threats that has to humankind. So, I think these are difficult. It would be nice to hear if people have other examples of community engagement. We don't always have to wait for these to be published. And it's nice to create fora like this to also share best practices early on and scale them up.
Yeah, got a question about.
Sorry.
Just a quick question, follow-up question about the initiative you launched, Convince, and engaging with business who had a real vested interest in getting us back on track. And we're engaging with their employers. Some of them, provide the health insurance for their employers. So this was a U.S. initiative. Has there been similar initiatives in other parts of the world that you're aware of where business has organized around this particular issue?
Well, thank you, Jeff. Our intent was, when we set it up with Heidi Larson, Ken, and Nancy Lee of Wilton Park, the goal was to be global in scope, and the business partners Convince link with the U.S. Council for International Business, does work with the International Organization of Employers out of Geneva, does work with the Business Industry Advisory Council of OECD. So we have presented at those areas and have created modules that, when I just presented this actually recently at an OECD meeting, the question was not only what are you doing for OECD countries, but what about the developing world, the other LMICs, to lower middle income countries. And the point is that we tried to create modules that business can use. So they're just learning modules, bringing science-based people and experts in different fields. The fact that we tried to work, and we still work with the Australian Chamber of Commerce, has a great red, green, yellow light system, a warning system that they put in place. Some of the other groups, and they're Trinidad, Tobago, some islands that needed it in the Caribbean, they worked with us. But it'd be nice to say I have an evaluation paper that points to the uptake, but it's very difficult to get that evidence and information and assessment of it. So I think that's what's happened with a lot of the initiatives over the last couple of years. We've had a lot on COVID. Now we need to collate those and curate those and take best practices and move forward. And that's why I really commend the efforts that you and Cooney and we've all been doing of looking at this now. We're 4 years, but now what? What can we do? And I see Nina has her hand up. And
Nina has her hand up. Yes, please. You're on mute.
Sorry about that. I think in addition to those efforts, I really COVID-19 made me really think about what we mean by community. We talk so much in public health about community, and I think that like your colleague who said that trust is hard to gain and easy to lose. Community systems are fragile and expensive, and going door to door and getting trust door to door with your neighbors and your neighbors' neighbors and out in your community. The bottom line for me is we have to invest in primary health care. We have to invest in systems that people trust in health. We can't just sort of fly in when there's an emergency and say, trust us. And I am saddened that I don't think that message has gotten through, really. And I think when we say talking to community, I think what mostly happens by the political level is talking to the community leaders who are not necessarily the so-called appointed community leaders who are not necessarily engaged with their communities. And I'm going to give a positive example in a sec, but I want to actually really interested by the rollout of the booster in New York City, where I'm also proud to be a New Yorker with my fellow colleagues from the City University here. But We rolled out, the booster was just rolled out to cities, but not to the community health centers within cities. We have a system in the US called federally qualified community health centers. They're where people who are mostly on insurance, low-income people go to health. And the COVID boosters were unavailable in these. So they were available first in the private pharmacies in New York City, but not available in these communities. What do we know about the private pharmacies? What did we learn from COVID-19? We learned that people without access to internet can't make an appointment. There's a ton of literature on this idea of pharmacy deserts. We know that people in very poor communities may or may not live near the chains that were carrying the vaccine. And this goes back to me about community engagement. And I think it's hard, it's tough, it's not very attractive, but it's really about talking to the people where they live. Now I want to flip to a positive example, which is something that happened in Ghana during the pandemic. And I can share a Lancet piece that we wrote about this, a little letter that we wrote, where urban women, interestingly, when they rolled out the COVID-19 vaccine, urban women were not getting vaccinated and rural women were. Interesting. So what did they do? They went to talk to urban women and they said, why aren't you getting vaccinated? They sent out health workers to understand why urban women weren't getting vaccinated. They work in markets. They couldn't leave their market station to go to a fixed site. So the city of Accra instituted a program whereby they took the vaccines to the market so that market women could get vaccinated. The community leaders, so-called, didn't know that was only able to develop and implement a system like that because they were really talking to people. So I think in this definition of community, we really just have to think again about how do we get to people, to people, to people, to people. Thanks.
Thank you, Nina, so much. And it brings us to the next most very important aspect of our study results, looking at our preliminary results on the issue of misinformation from this fourth global survey. And Trenton White, our colleague and fellow in our research group, is going to be presenting the results from this study. Trent, mic is yours.
Thank you, Ayman. Pleasure to be with everyone today. I wanted to take a moment to present a few of our questions on pandemic and infodemic fatigue. And before I do, I want to provide a definition of the infodemic, which the WHO defines as too much information, including false or misleading information in digital and physical environments during a disease outbreak. So what sticks out to me is that this is really about too much information too fast. It can be both online and offline, but the point is that during a disease outbreak or during a crisis, when you most want to reach people, there may be too much information and they're overwhelmed. So we wanted to ask participants of this global survey, if it's easy for them to know the difference between accurate and false information about the COVID-19 vaccine. We found maybe it's the case that the glass is 2/3 half full, but 2/3 of people were strongly agreed with the statement that it was easy for them to tell the difference. Now, having said that, we didn't test them on whether they could identify true and false information. And I think this question is actually a little easier to understand or more interesting to understand if you flip it and look at the third of people who say that it's not easy for them to tell the difference between accurate and false information. And in 2023 and moving forward, when generative AI and algorithms that promulgate false information are improving in their efficacy, this third of people are ones that we should really watch out for to understand who they are and how to reach them. Similarly, I'm bolstered to see that nearly 3/4 of the respondents report continuing to pay attention to information on COVID-19 vaccines, as well as other vaccines, non-COVID vaccines. But again, nearly a quarter of people say that they are no longer paying attention, indicating some degree of fatigue as we move forward in this post-pandemic, quote, post-pandemic period. Ayman?
Thank you so much. I really think that the issue of misinformation is not a small one, but also, drinking from the spout, as they say, is not a small issue either. Trent, let's bring back the full participants on the screen, and what type of misinformation exists and which have proven to be the most harmful or persistent in discouraging vaccination? Ken, what do you think? I don't see Ken. Scott, perhaps?
Sure. Well, I think the question is, it's really important because is there sort of a perfect piece or ideal information that would change people's mind? And it's not an issue of a perfect message or the perfect messenger. It's a matter, I think, of dosage, and dosage amongst the trustworthy, welcome sources that are important for people to make decisions. And to go back to the earlier slide, so my doctor, the learned intermediary that people respect for health, it could be a community health worker in some cases, it could be the pharmacist, it could be somebody at a pharmacy, it could be their high school teacher, in some cases, that are the intermediaries that are giving the information. So we have also had this other unique framing on vaccine literacy that it builds, that it shows it's not just the individual who has the skills and the ability to understand the information on vaccines and make the decision to get vaccinated, but the literacy angle and lens it takes also is to make it simpler. So Nina's example of bringing the vaccine in a crowd to the market is as important as we are trying to bring the vaccine in New York City to a place of worship, rather than thinking it needed to be at stadiums or other places. So it's a long answer that, one, there's no answer, there's no universal answer, there's no universal message, and there's no universal answer. Facts matter, but also getting facts in the belief systems that people have and tailoring them to the appropriate audience. And I'm just going to hold up, people might not be able to see, but I've saved some old articles that I thought were interesting. And this was a New York Times article in March 2020. And the title says, "Who's at risk? All of us." But why I saved it is this chart, which are like bubbles of people who are most at risk. And of course, you had healthcare workers at the top here. But the point is that all these people were at risk, but we were trying to use a shotgun approach or one message to reach all of them in terms of building trust. And we didn't create that trusted intermediary. So in the future, we need to help create a trusted intermediary that then also has information tailored to people that they can understand and help them make decisions. And that's kind of been the thinking around vaccine literacy. And we started and published it, but there's a group out of Florence that's just written an article in BMC Public Health on the promise. There's others in different parts of the world that have been using this lens that takes it more out of the education side or the health service side and brings the sectors together. And that's where I think there's promise for the future.
Yeah, I think your answer is translatable also to misinformation. It's not just the message itself, but the messenger, and how much people trust the messenger of inaccurate information. We've heard pseudoscientists, we've heard politicians, we've heard religious leaders, we've heard media experts who have participated in that misinformation campaign. And for people who in a community, if they see that person who is trusted to them disseminate misinformation, we're seeing very high profile political leaders sharing through their pulpits misinformation to groups that trust them. And that in itself, I mean, the question was originally the message that is most potent, but I think it's the messenger as well, where the misinformation is being disseminated through. Jeff, it's yours.
Thanks. I mean, throughout at least the later year or the latter year of the pandemic, it made me think that, we have this bottom-up approach where we're trying to, go to the communities to reach healthcare workers in primary care and sort of one by one try and address, or community by community, address the misinformation, the malinformation, the false information that's circulating, in the society. And at the same time, it can be debated, but we have sort of trusted sources of information. And I think specifically like to the debates on some of the big channels. I realize we may not all trust anymore Twitter and X, but I mean on Spotify and Facebook, and this group is a sample that maybe is probably a lot more critical than most people out there. But we couldn't even get some of the big platforms to take down knowingly incorrect information. And so while we're trying to mitigate this, a bunch of public health and other experts explaining this and doing a few interviews or a lot of interviews on broadcast media, TV, social media, newspapers, we have the largest channels not bringing down openly false information. I'm not talking about the controversial information, but really what was shown to be correct. And it makes me think of what one of my colleagues said to me, and he said, if you get insider information about a company and you use it for financial gain, like buying or selling stocks, the people who share this information, can be charged, right? You can go to prison for this kind of inside information. Yet when you share false information that can lead to the situation we were in or continue that situation, nothing seems to happen. We can't even take it down from channels that should be to some extent, regulated, at least within, the laws of the country they're in about what you're allowed to publish or not. I mean, there's plenty of countries where you're not allowed to say certain things because of the history they've had. Germany is a good example. And yet here we have false information, more than lingering, being knowingly spread. So I just wanted to just bring up that issue, and maybe, again, our communications experts, Ken and Scott, have some thoughts on that, because there's a real push against any kind of regulation of social media. I'm all for free expression, but what do we do when false information is online, and how do we get it off rather than tell people that it's incorrect?
So accountability, right? Yes, yes, Ken.
Earlier about how hard it is to get back to a level of trust that we once had. And that's what you're up against when you're trying to say, gee, misinformation is out there and misinformation hurts you. No attempt to regulate the social media in the United States of America, at least, is going to work, and in few other places. The only thing we can do is to help people understand what misinformation is and how they can interpret that. Those are the kind of things that the Coalition for Trust is trying to get into. Programs to help people understand what's coming at them so that they can sort out helpful information from unhelpful information. These community matters also, by the way, I just put up something. There was an organization in the US that was funded to start things happening at the grassroots level called Made to Save. And they were very effective. And their final report is very instructive. There are a lot of good examples of community programs to encourage vaccination, all in the genre that Nina was talking about, because she knows what she's talking about. It's going to take a multifaceted approach. It goes back to our consensus study. This is all players, multidisciplinary. And that is difficult for people like us, because communication cuts across the traditional disciplines that we all practice. And there's, as a result of that, there's always been a sense that the communication, anyone can do that. Anyone can communicate. We communicate all the time. But in fact, communications is a profession all by itself. And health communications is something that is unique. And we have to master it. And we have to teach our colleagues to master parts of it, and also to know when to ask people who actually are experts in this to help them out. This is a terribly complicated issue. And misinformation is going to go away.
I mean, what you're saying about asking the communications experts, I mean, when I debated this, the Spotify issue with Josh Rogan and all that, I mean, I realized that this was a legal issue, and we needed to bring lawyers in to discuss this. This wasn't about communications. This was, like you said, about accountability. I mean, what is allowed within the law? And I don't know, I don't want to jump the gun, but Nina, in the pandemic treaty, which you've read many, many times now and have been contributing to, I mean, are those issues being addressed? I mean, we talk about how the health system needs to be ready. And I know there's a mention of a whole society approach in the pandemic treaty draft that I read earlier in the year. But I mean, are issues around, the regulation of information to the public being considered?
Not to my memory of the text, actually. I would have to reread it, but I would have to check. Jeff, I can check even over the course of the next few minutes, but I have to check. I don't remember that as being part of it.
I don't either. I mean, and I read, a draft a little while ago, but I mean, the fact that it's not, and that I think it's playing such a role in preparedness, and in even trying to end the situation we're in now is striking. So there's going to be a lot of information. We'll talk about that in our last portion of this meeting, but there's going to be a lot of good information and let's say actions set out in that pandemic treaty. But if we're not addressing the information issue, we're going to have a big challenge. And I realize that some countries will push back really, really hard on that. But at least in the countries where some of these large platforms are registered, I hope they'll support that kind of consideration.
Thanks, Jeff, for raising the treaty. I know we're going to get into it, but if a treaty doesn't get ratified, what kind of value that's going to be? And you started this conversation, I think, by saying the international health regulations were not followed in the early parts of COVID as well. So while I may be hopeful about the health diplomacy efforts that are out there, I think you are right that we need legal interventions. And at least in the United States, 41 state attorney generals have already filed a case recently to go after the major companies in terms of harmful communication on mental health of youth or children. And I think if there's any lessons that we learned from the tobacco control challenges that were also done by the legal state attorney generals and others, those are the pieces that make a difference when you start with children. So children are being harmed. They're being harmed, what we mentioned, with not being vaccinated. Yes, the misinformation intermediaries or the anti-vax and other people are amongst those, but there's other pieces that are there. So framing is really key on this too. And I do agree that we need to really think seriously. The UK came out with some regulating on AI this week. Yesterday, I think, President Biden issued an executive order in the US. You have companies that have come together with some ethical AI principles. All of these, I mean, that's the next horizon frontier that's going to be an issue for us if we don't get on top of it as well. So we can't look, we can look retrospectively at what we learned through communication, but we need to think prospectively of how we regulate, or lack of a better term, help give guidance at least to have the ethical communication that's necessary. This is a big issue. This is not going away, and we have to tackle it all together.
We have in the
sorry. Go ahead, Ayman.
No, I was just I just wanted to mention the concept of cross-sector collaboration in that realm, and how can we bring various sectors together? You've already alluded to this, but are there good examples where multiple sectors are collaborating towards the same end? Trent, you have any ideas?
Well, to put it simply, I think health authorities in general provide the accurate evidence-based information and then collaborate, for example, with tech companies, with other communicators to make sure that the right information is out there. But we're not the only ones communicating with them, as we've just mentioned. There are other bad faith actors that are promulgating information. Scott mentioned the presidential order outlining new standards for artificial intelligence safety, meaning that it will be easier to identify misinformation. I know that the EU has a Digital Services Act, which obligates, quote, very large online platforms, so X, Spotify, Facebook, to assess the risks that they pose to the public and implement mitigation measures against the spread of illegal content, illegal content and misinformation. So primarily the focus until recently has been on terroristic or violent language and hate speech, but increasingly this is being directed at health misinformation, other types of harmful misinformation.
If you have your hand up.
Yeah, I would just say, I mean, we can look to examples of where we realize that a health issue couldn't be handled by the health authorities. And I mean, and HIV is the most obvious of them. And if you think of the prevalence, past and present, of HIV, and you compare that to how many people have had COVID, how many people have and still have long COVID, it pales. I mean, but we have a UNAIDS that brings together 11 agencies. We have organizations that are just focused on the economics of HIV, that are just focused on communications around HIV. We had offices for HIV set up underneath the presidential offices around low-income countries to handle support from the Global Fund, from PEPFAR, from other large funding resources. And then I think where are we now? We're trying to turn the page on COVID-19. We're talking about a treaty that's if it will go if it goes in May 2024 for the discussion and ratification. I've seen versions that seem a bit watered down from what I'd like to see, and we'll come back to that in terms of accountability. And I just feel like we're not taking on this kind of communication aspect seriously enough, and we're not reaching the response level seriously enough. We haven't had that kind of coordination that you have for other conditions like HIV. So I don't know if there's any other questions or comments. Also, folks, you're welcome to use the chat. You're welcome to raise your hand and say something. Otherwise, Ayman, we might want to continue to the next
Yes, I
section.
think you are in charge of the next section, Jeff. So
Yeah,
you take the bull by the horn.
I will. Nice metaphor for a bull runner like myself. So, so in this last section of this meeting, we wanted to talk about future preparedness. So remember, we started talking about the focus on vaccines, the thoughts already in 2020 that if there's an effective vaccine, people will take it, to broadening out now with additional support, the survey to really understand what is driving this vaccine hesitancy, and showing some, I think, positive developments, but showing that we're not ready yet. We also asked some questions about future preparedness now. I would say preparedness for the current situation, but also for, as was mentioned, by Nina, for disease X, for anything that might come in the future. So we asked, respondents to respond to, I believe the COVID-19 pandemic is over. If it's been declared over, as some people have told me, then it must be over. And here 38% agree, but 39, almost 40% disagree. So this is very interesting because on the one hand, I'd like to see agreement with a WHO declaration. On the other hand, for people affected by COVID, both with acute infections, but also with long COVID, they don't feel the pandemic is over. And sometimes we need to remind people that it's a very political decision as well, to determine when a pandemic is over, impacted by economic, political, social, cultural reasons. Next. So how confident are you that we will manage the next health crisis better than the COVID-19 pandemic? I mean, if a lot of people think we handled this pandemic poorly, I would have liked to have seen this number much higher at 75%, because in some countries it was hard to imagine how you could do things much worse. Spain, where I was living and working, would be one of those, certainly parts of the US. So 75% responded. How confident are you that we will manage the next health crisis better than the COVID-19 pandemic? Only 75% say, yes to that. Next. If the WHO, if the World Health Organization announced a new pandemic threat, would you trust this information? Just 2/3 would trust that information. It's important to remember and to remind people, because many people on this call are influential, and you'll reach out to others, that WHO is governed by its member states, right? So there's over 190 member states of WHO. So when WHO makes that declaration, it's on behalf of the member states. And yet a third would not trust the information. Going back to what we talked earlier about who do you trust to get a vaccine? Here we see that the highest health body in the world, specialized agency of the UN, is not trusted. If an mRNA vaccine is approved for a disease for which you are at risk, would you take it? So 2/3 would, 1/3 is not. I realize, reading the question that it can be a bit vague because, do we get vaccinated for everything we're at risk for? How do we determine that? But I think, participants understood that if you're determined to be at risk and you get recommended this vaccine that was developed on the mRNA platform, a third would not. So there have been, and we'll talk about this, issues around the different platforms, as Nina already mentioned, and as we repeat over and over to people. This was not a particularly quick vaccine development with the mRNA. This has been, in development for a long time. The missing piece came during COVID-19 pandemic, which allowed Moderna, Pfizer to produce those vaccines, or develop them and then produce them quickly at the end. Mm-hmm. Next. And if the World Health Organization announced a new pandemic threat and advised getting vaccinated, would you? And I think this is the most, for me, concerning finding. In fact, it's much lower than the number of people who have been vaccinated for COVID-19. So 63%, under 2/3, would get vaccinated if a new pandemic threat was announced. And that's where we need, that's the pivotal issue, I think, around future preparedness. We can have a treaty, and it might even be an excellent treaty with strong accountability, but we still have 1/3 of the population that says they wouldn't get vaccinated. So that's what we need to be addressing. I see a question already. How have you calculated these percentages? These are percentages based on the overall number of respondents. When we publish the paper, we'll share this by country, and you will see great variation by country. So you will see countries lower than 63%, and you will see countries in the 70s and 80% range. And then you will see differences by sex, by economic status, by education, and so on. So these are just the broad stroke findings to inform the discussion. Next. So you can, we can leave that up. And let me to stop that my part on those high-level findings. And before we move into a discussion, pass over to Nina Schwabe to talk about the pandemic agreement. Thanks, Nina.
Great. Thank you, Jeff. And those are certainly sobering numbers, very sobering numbers. So I'm going to talk a little bit about the pandemic agreement. Scott was a pessimist. I'm an optimist that says that there still is room to come together, come to agreement, and talk a little bit about how we govern pandemics. Because I think a lot of what you found in your work has been so influential is trust comes from the top. It's a top to bottom issue. I've got to trust our political leadership. We have to touch our community health workers, our healthcare providers. So trust is in a way end to end. So this is about trusting, how do we trust that this is all going to be governed appropriately? So next slide, please, Trent. So there are a couple of different processes that are undergoing or underway at the global level, which are called sort of the global governance around pandemic response. One was a high-level meeting held at the UN this fall, which tried to galvanize political leaderships, heads of state behind pandemic preparedness and response. There's the working group on the international health regulations, and then a treaty for an international intergovernmental negotiating body for a new treaty. And that's a little bit what I'll focus on today. Next slide, please. So these three processes serve slightly different purposes. The high-level declaration is exactly as called, high-level heads of state, get some oomph behind caring about what comes next. The IHR is more technical. Its primary purpose is around preventing and controlling the spread of disease. And it's really focused at actions that each state has to take. And the pandemic agreement, which has been previously called the Pandemic Accord or Pandemic Treaty, is about how do states work better together and show a united front next time for the next pandemic. Next slide, please. So the process started quite early on. So there was a big call to action where states realized that they needed more than these technical regulations. And let's put aside how many states adhere to the technical regulations or whether they're working. But there was an agreement that we needed something bigger and better, and that helped states figure out on a technical level, not just a political level, how to work better together. So when this comes to fruition, it will technically be legally binding. Countries will have to, as Scott mentioned, will have to actually ratify it. So for example, if you live in the US, the Congress would have to ratify it. And while all states are involved in the negotiation of it, states will have to sign on to it. Next, please. So we're pretty far down the line of the process, declared as an interest in 2020. The first draft of this treaty, or now it's called an agreement, came out in December, and a draft was released on the 16th of October, which is now a so-called negotiation draft. So lots of every countries at the World Health Assembly, as Jeff mentioned, countries are represented by member states, all of the countries of the world, minus a few. Most of the countries of the world, almost 99% of them, come together and they negotiate and they come to agreement on topics that are important in public health. So those, when we say negotiating, the people that are negotiating are countries themselves and delegations from all of the countries of the world. Next slide, please. As I mentioned, it's about global collaboration, and the text includes lots of things. It talks about equity. That's really the most important principle. It gives targets and priorities. It talks about sharing samples. It talks about strengthening national health systems. Unfortunately, I don't think, and Jeff and I will double check this, it talks about strengthening information systems or addressing mis or disinformation. But we'll get back to that. And it talks about One Health, so the interaction between humans, animals, and the planet. Next slide, please. The treaty itself looks like a regular old boring document, but the devil's in the detail, and that's what's on the right side of the slide. So this, as I mentioned, the draft was released on the 30th. You can find it on the internet. I can post a link in the chat after I've finished speaking. And it deals with a number of issues, each of which is articulated in an article. And what happens next is that the member states, governments go through article by article and they negotiate each of these points. Will technology be shared? Will intellectual property be shared? How will we think about fair allocation of vaccines and other supplies when and if the next pandemic comes? How can we do better about streamlining regulatory systems so that every country doesn't have to have its own, et cetera, et cetera. So there's a lot to negotiate in there. Next slide. Also, people have to agree. And again, Scott mentioned this. So a lot of people were behind the development of the agreement, but whether or not states will sign it, the first step is signing it, and then the Congresses or various parliamentary bodies have to ratify it. That's another question. So this is after it's come to agreement. Will people actually sign it, and will it come into force? Really important question. But again, we're going to be optimistic that people don't want another pandemic and they want to do a better job next time. So I'm going to be optimistic on this one. Next slide, please. So then there's a question of once you've signed it, then what? How do we make sure that people do and member states and our governments do what they've signed to? So there's three mechanisms built in right now to the language of the treaty. One is a so-called conference of parties. And that means that that's just another way of saying the states themselves that are going to sign on to it. And what it means by conference of parties is that you're only party to the treaty if you've signed up to be part of the treaty. So states, if, for example, state X doesn't sign up, they're not part of the governance of the treaty. But any states that sign the treaty, and usually the ratification can take a long time, so there can be a delay between the signing and the ratification. But let's assume states sign on, they're the conference parties, they're the uber governing agency of this treaty. And then within the treaty itself, there are a couple of different mechanisms for how it'll be monitored. One is a peer review. Literally, states will go in and look at each other's systems. And the other is reports that state will submit every year and there'll be a review every couple of years. And this is all documented in the draft of reports that they submit up to the governing body, the Conference of Parties. We believe, and others believe quite strongly, that there's another element that needs to be included in here of independent monitoring. So do states submit correct information? Do they submit timely information? And do they submit complete information? Next slide, please. So we're proposing that the Conference of Parties also develop a committee which does this. And these are just some concrete terms of reference, because when you say there has to be independent monitoring, and I think if we look at the initial COVID-19 coming out of China, can it really be done? We just think it can be done. And there's lots of ways and lots of examples of how it can be done. Next slide, please. So we're asking as part of this, and we hope those of you who work in this field to say, okay, very specifically as part of article in that document I showed you, which was all the different articles that need to be agreed, we think there's easy room to put in a call for independent monitoring of member states to see, are they submitting reporting? Is it complete? And is it accurate? Next slide, please. This is our reports, which I can put in the chat and will be published. We'll have a BMJ article coming out. It may probably tonight, and a Lancet piece coming out in the next couple of weeks also on this same topic. Next, please. So key dates moving forward for those of you that are interested. Draft has been circulated. What I say when I say meeting of the INB, the Intergovernmental Negotiating Body, that's exactly what it is. So they're going to start negotiating. This is the beginning of the negotiations. Start on Monday. We're off to the races. And the idea is that the draft has to be negotiated by the end of March in order to be submitted to the World Health Assembly, voted on by member states for adoption. Next slide, please. So that's it. And really happy to have spoken to you today. We try to do live updates on this on Twitter just to get information out. But you're also welcome to contact me if you have questions about this extremely esoteric subject. Thanks, Jeff.
Thank you, Nina. I mean, I can't emphasize enough how grateful I am for everything you and Spark Street's doing. I mean, the analysis, the staying on top of it, unpacking it for us. Trent, you can close, I think, the slides, and we'll move into some discussion. And so Nina, if I understand it right, I mean, one, there's a risk that it just doesn't make it for May 2024, which is when the World Health Assembly meets. I see you nodding. I spent 11 years at WHO, as you know, and my guess is that there's going to be a very busy week the week before of all of the last agreements. So whoever's involved in negotiating and monitoring this, don't go on holiday that week, because it always comes down. So it seems like everything's okay here in November, but you had all those INB 7, 8, 9 meetings scheduled. Now, let's say it does get approved. I mean, it does reach the World Health Assembly and they agree on it. You said every country will have to go back to their equivalent of, we're in the US now, of, sort of the Congress to get approval. So we're going to need that 150, 190 times, right? To get the treaty approved at the national level for it to take effect.
Yeah, I think there's some interim. I think also let's just go one step at a time. Let's get a good solid document. Let's get member states excited about it. Let's get some agreement about it, and then we'll go one step at a time. I mean, yes.
Okay, I'm just thinking, anticipating that we want to start advocating, in countries to support this, and make sure we're monitoring that process when we
That's a really important point, because already there's been a lot of disinformation and misinformation around that issue. And that's actually an excellent point, and very germane to the topic that we're discussing here today. Is there have been already, particularly in certain high-income countries, sort of treaty, national sovereignty, don't tread on us. So if we look, we've been following a little bit the press in the UK, and even Mr. Musk had sort of a tweet around this earlier on, where he took on Dr. Tedros, who's the head of the World Health Assembly. That was maybe in the spring. We thought it would get more traction, but thankfully it didn't. I don't know why, but in the UK, this is a very hot issue, where there's kind of like Brexit exit, don't tread on me, we don't want no treaty. And I think what we've seen is, as you've seen, and this is a bit of a pundit view, you guys have done expert research, like proper research, but just from where we sit, we see an alignment with the anti-vax movement. We see the same people tweeting as the anti-vax movement. We see that aligning with other, I would say particularly with the same people who are tweeting about the anti-vax movement. And for those of us on this seminar who are on Twitter, I think we've all been attacked over the last couple of years, either through email or through Twitter. People bounce at us. And I think certainly through my tweeting about this, I've seen the same voices out there who really fear. So there's a big misinformation campaign happening around this.
Well, I'm glad we're aligned in that thinking, because the sovereignty issue is the key issue around accountability. We see that in the EU, where health is traditionally in the domain of individual countries, and we saw attempts to overcome that with pooled procurement of vaccines. But now we'll see it with the treaty again. Are there some aspects that are more controversial than others? And while you think about that, I mean, remember, IHR was approved and did, let's say, take steps across people's sovereignty lines to some extent. I mean, I remember when it was being negotiated, I was at WHO back in 2005, and we saw that as sort of that this is the answer. This is how we're going to do it. But so are there some aspects that you think are going to be easier to get agreement on others? And then I would just add, because you mentioned some of the research we've been carrying out. Again, we're working against forces that are very well organized and opposed to this. But I mean, we do have a World Trade Organization, and when you violate intellectual property rights, there are serious consequences for countries. We have an international crimes court. Not everyone's a party to it, but those who are, this goes above sovereignty. So there are examples out there of where this happens. WHO's typically not one of them. I mean, it makes normative guidance, sets standards, recommendations, pre-qualifying treatments and diagnostics. But we certainly have things that countries have agreed to, including the US, where we're sitting. So it wouldn't be the first time we ever agreed on a treaty. We also have the Tobacco Framework Treaty. So over to you, Nina, to maybe walk us through or mention some of the areas you think that are going to be easier to agree on or more challenging.
Yeah, those are two great questions. So I think the areas that are definitely trickier. So equity, people are supportive of equity. It's a good thing. Strengthening community health worker systems. There are things that are generally going to be less controversial. The things that are definitely more controversial are around waiving of intellectual property rights, for one, which has come up already strongly with Germany at the Berlin conference taking quite a strong and public position that hell no, we won't go on that one. That's going to be a tough fight because the G77, as part of the negotiations for the high-level political declaration that I spoke about, that's a deal breaker on their end. And we saw those same you mentioned the World Trade Organization, we saw those same debates around vaccine access. Those are going to repeat themselves. Another issue is this idea of what they call access and benefit sharing, which what that means is the classic example is when South Africa discovered the Omicron variant, they said, hey, we discovered this, here, take the genomic sequence. And everybody said, okay, close the border with South Africa. They're like, wait a second, that's not fair. So this is this idea of how do scientists share, and then also within the sharing of access, for example, to genomic sequences, if we have major pharmaceutical companies taking those on, how do scientists and countries that share actually benefit, particularly for low-income countries who feel that they often share without the benefit. So those are two, I think those are going to be the two trickiest ones to deal with. And then you asked, what was the second question about, sorry.
Well, yeah. I mean, what was difficult and what will be easier? And you just mentioned, some of the lines in the sand countries have drawn.
Yeah, and yeah, so I don't know. Again, we'll see where it goes. We'll see where it goes and how it goes. I think as well, one of the things that we saw in the negotiation of the political declaration in September is we're not in a good place politically. We have real division, even worse in the last couple of weeks than it was 3 months ago. So that's not great for coming to global agreement. It's not a good sign.
So, and now for the IMB, for the actual negotiations, how much of that is public? How much, I know you've been able to follow them, but are we able to see them, read? I mean, you mentioned some documents get posted online, but
the way that those negotiations work, or they generally have an opening session and a closing session that are open to the public. The opening, they say, here's what we're going to do. There's a chance for what are called registered stakeholders to give comments or to submit comments to the process. And then at the end, they give you a summary. But these discussions are with, by, and for the member states and the delegates, and they are not publicly open. At least not at this point, although people are arguing for that to happen.
One would think this would be transparent given what's at stake. Scott and Ken, as communications experts, I mean, are you seeing much chatter about the pandemic treaty? Is this coming up, with the journal, with like the Convince or any of the collaborations you have with business and others? Because there's going to be a lot of work. Even in a best case scenario, it gets approved in May and it's a strong treaty. It has to be approved nationally. So we're going to need to really prepare the ground communications wise.
We're thinking about it as you and Nina were talking, and Nina, you seem to be pretty close to the process. Are there any soundings being taken at national levels? Is there any social research being done to find out how aware people are or are not, or how open they are or are not to the whole concept of the treaty? I would shudder to think about launching this thing into a void. You really have to have a prepared audience, and I'm not sure that we're close to that.
Yeah, not to my knowledge.
Yeah.
Give it some thought.
Well, yeah, I mean, Jeff, to answer your question, and I think what Ken's raising is there the burning platform that people will be paying attention? And I know that obviously diplomacy, it'd be nice to have a treaty that's ratified. And as you know, the US has never signed on in the Framework Convention for Tobacco Control either. But the three things that I continue to bring up when I make presentations and talk are that we need reform in institutions. So Helen Clark's comment on the independent panel for pandemic preparedness and response now in 2021, when she says current institutions, public and private, fail to protect people from a devastating pandemic. Without change, these institutions will not prevent a future one. So take that to this treaty? Are we have the same institutions? Are they just going to be new or updated regulations? That's just sort of a question of what the final document looks like. And then I think what's very interesting this week is the Global Preparedness Monitoring Board that I referenced earlier just came out with a report earlier this week talking about what I think is very interesting from the two chairs, one former president of Croatia that says, she said, it's a year that a lack of trust at every level, both between and within countries, remains a significant obstacle to preparedness. Again, the trust issue. And the other co-chair from Botswana said, there are many efforts underway to strengthen preparedness, but they will fail without the right resources and support. Leaders must double down on our commitment to learning from the lessons of the past, creating a world where we're all safe from pandemics. I think these are high level, well, obviously, former leaders of a very important member states who are part of this, calling for something. They're not, we're not calling out the word as a treaty, but we definitely need some major reform in this regard. And I want to, thank Nina for all the great work. I've seen you now present this twice, and I know that's it's a lot of work, both behind the scenes, what's current, and getting the right member state and others to support it. I'm just, frankly, from the global health diplomacy standpoint, from a meeting earlier this year at the Council of Foreign Relations talking about this in Washington and others, I'm going back to the Dean's presentation. I think the glass is less than half full on this. I'd like to really see it move forward, but unfortunately, what I'm hearing on the ground sort of answers the question, Jeff, from the stakeholders that might need to make a difference, is it's not at the level that maybe it needs to be.
I'm going to give the Dean a few minutes to think of how to end this on a positive note while I make a comment. Because I do think we need to be positive. I mean, we are, like Nina said, we are in negotiations around pandemics, and it's not like, I was at WHO in 2009. There was the start of a pandemic, and we were, much less prepared and not prepared to have these kinds of discussions. So the fact that we are negotiating is incredibly important. I mean, I firmly believe, as I said earlier, that, we can have this bottom-up approach that we need, right? I mean, we need to engage with communities. We need to reach people who want to be reached from at every level, from the religious setting to their GP to the community health worker, nurse, and so on. But the big change is going to come when it's top down. We saw what happened in this pandemic, and we saw how structural issues were, where you want to get vaccinated and there's no vaccine, where you want a booster but there's no pharmacy with a booster available near you. So there are structural issues, and I mean, I shudder to think that the treaty can be so delayed that we won't be prepared for what happens next, and we're going to need to think. And this is on you, Scott and Ken and others, from a communications perspective, what are things we can already do now that the world just doesn't need a formal agreement on, but needs to start addressing now? And then what needs, actual international collaboration? Because we can get pretty far. I don't know if it's 70 or 80 or 85% without the treaty. I mean, we need the treaty to bring it home. But there's a lot we can be doing now, and a lot more we can be doing now. And oddly, at a time when there's what I hope is more than a lull, which is a lasting decline, in cases and in severe cases, and we have a chance to breathe and discuss like we're doing on this call. People are already talking about, moving on to other issues. They don't see this as a priority. Funding gets dried up, and I'm not thinking just from where I'm sitting as a researcher or even as an advocate, but really, some of the health systems strengthening we saw happening during the pandemic, the growth in digital technologies, engagement online and video, peer support has also sort of come slowed down again, if not come to a standstill. So I think we need to be thinking about, as we start to come to a close, and I'll pass again in a moment to the Dean to conclude, but I think we need to be thinking about moving ahead, and we'll probably look again to you as well, Nina, about what can we be doing now internationally and globally that doesn't require a treaty in place, and what is going to be the added value of the treaty that we're going to push to support, so we can have that treaty approved in May and be much better prepared. So before I pass over, I'll just thank the panelists. This has been an incredible amount of work, and also thank the Consortium on Universities and Global Health for being willing to host this. It's great to be able to do this in a fora of so many universities that do have global health and public health programs. And with that, I'll pass over to you, Ayman. Thank you. You're on mute.
Thank you so very much. First of all, thank you to the panelists for a most informative session. I've learned so much from my colleagues, and some of whom I work with on a daily basis, and yet there is always much to learn. I also would like to thank the participants today for persisting with us. This is a long session with a lot of depth to it. So thank you for staying with us, and we promise that this will be available as a recording through Consortium of Universities and Global Health, and we will alert the participants of the availability. There are a lot of lessons learned, and I would ask Trent at the end, Trent at the end of the session to put on the website the consensus paper with close to 400 authors from more than 100 countries that have projected what they believe are lessons learned during the pandemic. One of the lessons that we have learned is definitely how to deal with issues of communication and hesitancy and trust that we covered today in great detail. Sticking to scientific evidence can never be overemphasized, but also humility to be able to say, I know when you know, and to say, I don't know when you don't know. This is really something that we have learned from this experience. Building coalitions, as has been emphasized tremendously by most of the speakers today, is essential in moving forwards. And avoiding certainty. There are many things that we continue to struggle with, and to learn from each other like we have done today, and to continue to gather information onwards, because data in itself evolves and develops over time. Always, as a result, the need to continue to evaluate. These are 4 studies that we conducted over a period of 3 years, and we have learned so much as things have evolved, and people's positions, as I've shared with you earlier on, and the rest of the panelists have shared, things have evolved, things have changed over time, and we need to deal with the here and now as people's attitudes and perceptions have changed. The importance of respecting the culture, and that culture matters, is very, very important. In many of the presentations today, we understand the importance of partnering with communities, understanding their perspective, and that in order to build trust, they need to be heard, understood, and respected. Seeking strong leadership is very important along many, many domains of what was discussed, in communications, in policy, in healthcare, in public health, and in advocacy. Leadership will continue to play a very important role. And as we pointed out earlier, the message itself is not the whole issue, but also the messenger. People are swayed more likely by a messenger than they trust, both in the positive and in the negative direction. And we need to be mindful of that. Mobilizing political will can never be undermined. And we need to, as Nina pointed today, I mean, really, your presentation, Nina, was so informative to me. And looking at that map, I don't know how to feel about it, but I will say that thanks to people like you dedicated to this mission, I have trust that over time, things may actually happen. So I thank you for what you do and how you do it. And then finally, always moving towards the issue of global health equity is the way forward for us to maintain credibility as public health leaders, as public health communicators, and as advocates for a global population. We have to understand that we are in this together. I will insist at the end of this presentation that without you participants, we would be flailing in the wind. So thank you for participating with us today and for listening to us. That is the best way in which we feel that the work that we do is meaningful. So you honor us, you honor the work, and we thank you for it. And I will insist in the very final word today that the glass is more than half full. Thank you, and until next time.